Hi everyone. Today we're going to talk about Chapter 3, the hematopoietic function, found in your textbook. Like the previous lectures, please use this PowerPoint as a summary of information found in the chapter, and be sure to I would still strongly recommend that you read the chapter and really take a look at the tables, figures, and other learning resources available to you. So blood is the life fluid of the human body, and it is essential for health and homeostasis. There are approximately 5 liters of blood circulating through the human body to provide nutrients and oxygen to tissues while aiding in the excretion of waste products. Plasma, blood cells, and platelets are what make up the blood, and disease occurs when there are too many or not enough or dysfunctional blood components. Blood disorders often present with manifestations in multiple systems. Therefore, an understanding of normal blood function, formation, and hemostasis are required to understand how abnormalities develop. Blood is considered by a viscous fluid and a connective tissue. Blood completes its tasks through its various components, which include plasma, leukocytes, erythrocytes, and thrombocytes. Plasma is a transport medium that carries the blood cell as well as the antibodies, nutrients, electrolytes, hormones, lipids, and waste products, with albumin being the most abundant. Leukocytes are key players in the inflammatory response and infectious process and consist of neutrophils, eosinophils, basophils, and mast cells. These cells are called granulocytes because of the granules found in their cytoplasm. 2 other types of leukocytes are monocytes and lymphocytes. Erythrocytes are disc-shaped cells that carry oxygen to tissues and transport carbon dioxide out of the tissues for its subsequent removal from the body, and contains a protein like hemoglobin which binds to oxygen, giving blood its red color. Thrombocytes, also known as platelets, along with clotting factors, control coagulation. They are carried passively through the blood and are coated with a sticky substance, allowing them to adhere to irregular surfaces. Clotting is a quick chain reaction stimulated by the release of thromboplastin from damaged cells lining the blood vessels in the area of an injury. Hematopoiesis is the process of blood formation, and it occurs primarily in the bone marrow, specifically the red marrow. This process requires an adequate supply of hematopoietic stem cells, which are considered multipotent cells in that they can differentiate into all blood cell types. Hematopoietic stimulus for red blood cell production may include hypoxemia and blood loss, whereas stimulus for white blood cell production may be infection and inflammation. In response to reduced oxygen supply, the kidneys produce the growth factor erythropoietin, which is a physiologic regulator of red blood cell production. Erythropoietin is essential as it amplifies signals in the cells for continued development and differentiation. While the blood cell is developing, proper cytokines and vitamin B12 and folate are necessary for cellular DNA synthesis and come from dietary sources. When the erythrocytes are developing, iron is also needed for the heme portion of hemoglobin. Heme iron, or iron mostly found in animal products, is more readily absorbed. Non-heme iron is primarily found in plant foods and dairy products. Once iron is absorbed and is in a free form and is labile, the labile iron cannot remain in this state because damaging reactive oxygen species can develop. This labile iron, the form that moves around, needs to be bound and used, transported, or stored. Hepcidin is a protein in the liver that tightly regulates iron uptake and transport in several places, such as the duodenum, liver, or spleen. When the iron levels are high, the hepcidin also increases and binds to the ferro portion, inhibiting transport action across the cell membrane so that less iron is absorbed. Low levels of iron lead to less hepcidin production and more iron can be absorbed. Alcoholism, chronic kidney disease, chronic hepatitis C, infection, and inflammation can all alter hepcidin levels and lead to iron absorption problems. The other mechanisms for iron elimination is through normal processes such as menstruation and disorders that cause bleeding or hemorrhage. Hemoglobin is a protein that carries oxygen, and it is produced while the red blood cells are developing. In order for oxygen to be transported and released, the iron in hemoglobin needs to be in the ferrous state. Some diseases and drugs cause the normal oxygen-carrying ferrous state to become the non-carrying ferric state, and this abnormal hemoglobin is now called methemoglobin. During erythrocyte development, the cell starts to eliminate its intracellular contents and loses its nucleus, making the cell smaller so that it can accommodate the synthesized hemoglobin. At this stage, the cell is called a reticulocyte, and once reticulocytes are in circulation, they complete their differentiation into mature erythrocytes. Hemostasis is the process by which bleeding from injury has stopped. This coagulation process needs to occur only where the injury is, so blood flow is uninterrupted to unaffected areas. This process requires factors that promote coagulation as well as factors that inhibit coagulation. Normal hemostasis requires endothelial lining integrity and platelets, and can be divided into two processes, the primary and secondary. Figure 3-7 in your textbook provides a great image of these two processes. When a vessel is injured, the goal is to decrease the amount of blood loss. To do this, the blood vessel quickly vasoconstricts under the influence of endothelium. Under normal circumstances, platelets are blocked from adhering to the cell membrane by nitric oxide and prostacyclin, and during injury, these levels decrease, allowing for platelet adhesion. The endothelial lining secretes von Willebrand factor, which in response to the injury binds to the basement membrane, and the platelet binds to this factor, which is the glue or link between the platelets and the area of injury. The platelets release various substances, which include von Willebrand factor, serotonin, and adenosine diphosphate, to activate platelets, which leads to aggregation or clustering. The platelets also release fibrinogen and calcium, which are needed for secondary hemostasis. The activated platelets release thromboxane A2, which is a potent vasoconstrictor and promotes further platelet activation and aggregation. And the second glycoprotein on the platelet binds with fibrinogen that is circulating in the blood, which leads to further aggregation and results in the platelet plug. The platelet plug is relatively weak, and fibrin will strengthen it. Fibrinogen becomes fibrin through activation of the coagulation cascade with the enzyme thrombin. The aggregated platelets, which in this example is the platelet plug, have a phospholipid surface where secondary hemostasis reactions occur. Inactive precursor coagulation factors, such as prothrombin, become active thrombin. The coagulation cascade can be divided into the intrinsic and extrinsic pathway, with each leading to a common pathway. See Figure 3-8. Coagulation inhibitors are important in containing the clotting area, and proteins C and S, along with antithrombin 3, inactivate coagulation factors. Deficiency in the coagulation inhibitors can result in the development of a DVT. The lymphoid system. So all the lymphoid organs connect the hematologic and immune systems, and components include the thymus and bone marrow, with the thymus of T cell maturation and bone marrow is the site of hematopoiesis. Other lymphoid organs include the spleen and lymph nodes, and the job of the spleen is to filter the blood, and the lymph nodes, which are masses of lymphocytes and fibers and are interdispersed throughout the lymphatic channels. As lymph flows through these channels, foreign substances and microorganisms are destroyed and the immune system is activated. Diseases of white blood cells. Leukocytes trigger the inflammatory process and fight infections. Leukocytosis is when the white blood cell is elevated, which can indicate an active infectious process. A decreased white blood cell count can indicate an immune deficiency. Neutrophils are usually the first ones on the scene of an infection or inflammation, and neutrophilia is an increased number of neutrophils. Bacterial infections are typically what trigger neutrophil release, but some viruses and fungi can stimulate this process as well. Neutropenia is a decrease in circulating neutrophils, and causes of neutropenia may include infection and inflammation. And in severe or prolonged cases of neutropenia, the usage of neutrophils increases, and the bone marrow cannot keep up with the demand. Bone marrow can also be suppressed due to therapies such as radiation and chemotherapy, or diseases such as aplastic anemia and leukemia. Clinical manifestations of neutropenia initially include signs and symptoms of bacterial and fungal infections, and the respiratory tract is the most common site of infection. Mouth ulcerations are also commonly associated, as well as ulcerations to other areas including skin, vagina, and the GI tract. Diagnosis and treatment revolves around the need to determine why the patient is neutropenic or neutrophilic. A bone marrow biopsy may be needed, and treatment is guided by diagnosis. Eosinophils and basophils are involved in the inflammatory response, most commonly during a late phase type 1 allergic response in asthma. Eosinophils can also be high with parasitic infections and with malignancies or drugs. Basophils are involved in the inflammatory response and release histamine and other mediators, and basophilia can occur during immediate hypersensitivity reactions such as food allergies or hives. Lymphocytes and monocytes are one of the key cells involved in the immune response, and increased lymphocytes are more likely to occur with viral infections such as hepatitis and herpes, but may also occur with some bacterial infections such as pertussis. Lymphocytosis can occur with lymphocytic leukemia and lymphoma. Lymphocytopenia also occurs in immunodeficiency syndromes such as AIDS or due to destruction, such as that which occurs from radiation or chemo. Infectious mono is commonly caused by the Epstein-Barr virus, and it can cause lymphocytosis. Monocyte alterations often accompany neutrophil alterations. Lymphomas are cancers that develop from malignant lymphocytes in the lymphoid tissues, and they are the most common blood cancer, and there are several types of lymphoma. Hodgkin lymphoma can start in any lymph node of the lymphatic system, but most often arises in the lymph nodes of the upper body. The two main types of Hodgkin lymphoma include the classic, which accounts for 90% of the cases, and the nodular lymphocyte predominant Hodgkin lymphoma. The types of lymphoma differ in the way the cancer cells appear under the microscope, and identifying which type the patient has is important because they grow and spread differently and can be treated differently. The incidence of classic Hodgkin lymphoma is on the decline and occurs primarily in adults 20 to 40 years old, with equal prevalence across genders. There is a second peak in men around the age of 55 years and older. There have also been improvements in treatment, leading to a decreased mortality by nearly 50% over the past 25 years. Nodular lymphocyte tends to affect males more than females, and the incidence peaks in children, and then again in adults around the age of 30 to 40. The survival rate is high at greater than 80%. To diagnose, a biopsy is performed and will reveal the presence of Reed-Sternberg cells for classic Hodgkin lymphoma and lymphohistiocytic cells for nodule lymphocyte Hodgkin lymphoma. And a staging system is used to grade the severity and progression of the disease. The staging system includes stage 1 through stage 4, with stage 1 indicating lymphoma cells are in one lymph node group, or the cells are not in the lymph nodes and are only in one part of a tissue or organ. And stage 4 is when lymphoma cells are found in several parts of one or more organs or tissues, or the lymphoma cells are in an organ and in distant lymph nodes. There is also a refractory stage, which indicates that the disease does not respond to treatment, either initially or after recurrence. And the recurrent stage is also known as the relapse phase, and it is when the disease returns after treatment. Staging is determined by using a PET scan, CT scan, MRI, and bone marrow biopsy. After diagnosis, treatment includes a combination of chemotherapy and radiation and bone marrow or stem cell transplant. The 5-year survival rate is 86%. Non-Hodgkin lymphoma can start at any age and in any lymph node, but most common in middle-aged to older adults and accounts for 90% of lymphomas and more prevalent in whites compared to other ethnic groups. With non-Hodgkin lymphoma, there are no Reed-Sternberg cells, and risk factors for development include the presence of an inherited immune or autoimmune condition, infection exposure such as H. pylori, toxins such as hair dyes or agricultural pesticides, obesity, and inflammatory GI diseases such as Crohn's. Non-Hodgkin lymphoma can be classified as aggressive or indolent. Examples of aggressive types include large B-cell lymphoma and peripheral T-cell lymphoma, and these usually present acutely with rapid mass growth, and death can occur within a few weeks without treatment. Indolent types include follicular lymphoma, chronic lymphocytic leukemia, and they may present with slowly developing lymphadenopathy, hepatomegaly, or splenomegaly. GI tract lymphoma may also have symptoms of anorexia, nausea, and vomiting, and weight loss. Central nervous system lymphoma may present with headache, seizures, and lethargy, and other symptoms patients experience may vary greatly. Diagnostic tests and staging are similar to Hodgkin lymphoma, but other diagnostic tests may include tumor markers, immunoglobulin studies, lumbar punctures, and blood tests for HIV and hepatitis. The overall survival rate of non-Hodgkin lymphoma is 72%. Multiple myeloma is a cancer of the plasma cells and is most often affects older adults, and this is classified as a type of non-Hodgkin lymphoma since the plasma cells originate from B cells. Median age of diagnosis is 66 years and more common in men than women, and blacks have about twice the incidence and mortality rates of whites. In most cases, before the development of multiple myeloma, normal plasma cells begin to respond abnormally to antigens. And the abnormal plasma cells make monoclonal antibodies, and at this stage, the asymptomatic pre-malignant disorder is called monoclonal gammopathy of undetermined significance. And these abnormal plasma cells are vulnerable, and if exposed to further insults such as genetic mutations, the condition can progress to multiple myeloma. The abnormal plasma cells also overproduce abnormal immunoglobulins, and the most common type produced is IgG. The most common chromosomal abnormalities are translocations. Deletions and chromosomal number alterations also cause malignant myeloma. Under normal circumstances, osteoblasts or bone-building cells regulate bone reabsorption by bone chiseling osteoclasts. Various cytokines are produced with multiple myeloma, affecting osteoblastic and osteoclastic activity, and plasma cells respond abnormally. Ultimately, the balance is tipped toward increased bone resorption, causing bone thinning, fractures, and bone pain. And the bone breakdown causes calcium to be released, resulting in hypercalcemia. Malignancy is often well advanced upon diagnosis, and clinical manifestations can be remembered using the acronym CRAB: hypercalcemia, renal failure, anemia, and bone lesions. Diagnosis is often made incidentally with routine blood work or images. The criterion includes monoclonal antibodies in bone marrow, urine, or blood, plus one or more of the CRAB features. All patients with suspected multiple myeloma need a serum protein electrophoresis. Multiple myeloma is not considered curable, but chemotherapy improves remission rates, and other treatments include corticosteroids, stem cell transplant, radiation, and biologic therapy. The overall 5-year survival rate is 54%. Myelodysplastic syndrome, or MDS, is characterized by a group of hematopoietic stem cell neoplasm. Red blood cells, platelets, and mature granulocytes can be affected, and nearly 1 in 3 people with MDS will develop acute myeloid leukemia, or AML. MDS is now considered a hematologic malignancy, and the incidence of it greatly increases with age, and the median age of diagnosis is 50 and is more common in men. Majority of the cases are thought to occur from years of acquired accumulated somatic mutations that can just occur with aging. Mutation by environmental exposures such as radiation or chemotherapy, or inherited mutations that predispose people to myeloid disorders such as leukemia. People with MDS may be asymptomatic and may be identified due to abnormalities noted on routine CBCs. Anemia may be noted and bring a long-term symptoms such as weakness, fatigue, and shortness of breath. Thrombocytopenia may also cause bleeding disorders, including easy bruising and bleeding. Individuals who have neutropenia will be at a greater risk of getting infection, and generalized muscle and bone aches may be one of the first symptoms along with anorexia. To diagnose, a CBC is often completed and may indicate anemia, neutropenia, thrombocytopenia, and pancytopenia. Bone marrow biopsy will be done, and genetic testing may be completed and show various mutational abnormalities. Treatments include observation and supportive cares, antibiotics if infection is present, and transfusions of platelets or red blood cells if needed. Growth factors may also be used to treat. Leukemia is a cancer of leukocytes, and in this disease, the bone marrow stem cells make abnormal leukocytes that travel through the vascular system affecting different organs. Leukemias are classified by their cell line, whether that is myeloid or lymphoid, and as either acute or chronic. The 4 most common types of leukemia are acute lymphoblastic leukemia, or ALL, acute myeloid leukemia, AML, chronic lymphoid leukemia, CLL, and chronic myeloid leukemia, CML. Acute leukemias are characterized by abnormalities in immature leukocytes, which are called blast cells. And the blast cells are categorized based on their stem cell line origin. Myeloblasts are from the myeloid line, where lymphoblasts are from the lymphoid line. The overall incidence of AML in comparison to other cancers is rare, with the median age of diagnosis between 65 and 70 years. Children can get it, with the highest incidence in children under the age of 1. ALL is more common and accounts for 75% of all leukemias and 29% of all types of cancer in children. In general, acute leukemia occurs due to genetic and epigenetic changes in precursor cells that lead to abnormal proliferation, differentiation, maturation, and resistance to apoptosis. The leukemic cells can also crowd out the bone marrow, leading to reduced production of erythrocytes, thrombocytes, and other leukocytes. The acute leukemias are genetically and phenotypically varied, leading to numerous subtypes of ALL and AML. Therefore, it is important that correct identification of the subtype is done, as it defines severity, influences prognosis, and guides treatment. Risk factors associated with the development of acute leukemias include environmental factors such as radiation exposure, chemotherapy, tobacco, or toxins such as benzene, the presence of other blood disorders such as MDS, familial genetic or congenital abnormalities such as Down syndrome, neurofibromatosis, or Fanconi anemia, Obesity may also be a risk factor as well. Acute leukemia may present with clinical manifestations that are associated with anemia, thrombocytopenia, and neutropenia. A person may also have lymphadenopathy, hepatomegaly, splenomegaly, cutaneous lesions, headache, seizures, and balance problems. Diagnosis through an H&P, peripheral blood smears, CBC, bone marrow biopsy are completed. And the goal of treatment is complete remission, but maintenance therapy may be necessary. Chemotherapy is the primary treatment, but radiation, biologic therapy, surgery, and donor lymphocyte infusion may be needed. Chronic leukemias are characterized by abnormal proliferation of more mature cells, and these cells have a similar appearance to normal cells but function abnormally. And these leukemic cells are found in the blood and bone marrow. CLL is the most common leukemia in adults, and the median age of diagnosis is 70 years. In CLL, proliferation is mostly mature malignant B cells, and T cell involvement is rare. CLL development is an interplay between genetics, epigenetics, and the microenvironment. CML is characterized by proliferation of mostly mature and maturing granulocytes that are fairly well differentiated. The form of CML is determined by the cell lineage, such as neutrophils or eosinophils. CML is classified as a myeloproliferative disorder, and the Philadelphia chromosome is present in 95% of patients. The abnormal chromosome is created during a translocation segment on chromosome 9, resulting in the BCR-ABL fusion gene on the Philadelphia chromosome of chromosome 22. This gene causes abnormal production of myeloid cells, which then leads to the start of CML. Most patients with CLL are asymptomatic initially, and the most common abnormal finding is local or general lymphadenopathy, primarily in the upper body. Hepatomegaly and or splenomegaly may also be present, and they may also experience fever, night sweats, and unexplained weight loss. CML has 3 clinical phases: chronic, accelerated, and the blast crisis phase. At diagnosis, most CML cases are in the chronic phase, and the person is asymptomatic. The phases are generally determined by the blasts in the peripheral blood and bone marrow. As a person progresses through the phases, the clinical manifestations become more prevalent and may involve fatigue, weight loss, diaphoresis, abdominal pain, and fullness. Progression between the stages may start slow, but progress faster with aging. Diagnosis often occurs with an abnormal CBC. In CLL, there will be lymphocytosis. In CML, granulocytosis and monocytosis will be present. And anemia, thrombocytopenia, and thrombocytosis are mild. A peripheral smear is ordered along with a bone marrow aspirate and biopsy. Erythrocytes are the most prevalent blood cell in the body, and most diseases of the red blood cells are related to the quantity or quality of the erythrocytes. Too few leads to anemia, and too many leads to polycythemia vera. Anemia is common and impairs the blood's oxygen carrying capacity and can result in a decreased production of red blood cells, as seen in iron deficiency anemia or bone marrow dysfunction. It can also result in increased loss of red blood cells, as seen in hemorrhage or blood loss. Anemias are classified in multiple ways, including the cause, the morphology, or hemoglobin content of the red blood cells. In clinical practice, morphology is the more common classification used, and some can respond quickly to an intervention, while others may last a lifetime. The clinical manifestations reflect the decreased carrying capacity and is often associated with fatigue, weakness, pallor, syncope, dyspnea, and tachycardia. Iron deficiency anemia is also a is also known as a microcytic anemia, and it is the most widespread anemia in the world. This occurs when the supply of iron necessary to produce hemoglobin is inadequate to meet the demand of hemoglobin production. This may be caused by decreased iron consumption, decreased iron absorption, or increased loss related to bleeding. When an iron deficiency exists, hemoglobin synthesis diminishes. The erythrocytes become pale because the cells have less hemoglobin, and small because the cell is trying to adjust for decreased hemoglobin. Therefore, they are considered hypochromic and microcytic. Besides the already discussed clinical manifestations of anemia, in iron deficiency anemia, the person may experience cyanosis of their sclera, brittle nails, spoon-shaped nails, decreased appetite, headache, irritability, unusual food cravings, and delayed healing. Children may develop irreversible neurologic damage without adequate iron, and manifestations could include slower visual and auditory processing, decreased attention span, learning difficulties, and motor impairment. Diagnosis is achieved through a CBC, ferritin, iron, transferrin, or total iron binding capacity. The red blood cell will reveal microcytosis and hypochromia. Ferritin and iron levels will be low and transferrin will be high. Additional tests such as a colonoscopy and endoscopy may be performed to identify the cause. Bone marrow biopsy will confirm the reason, but it is invasive and oftentimes not needed. Treatment includes identifying the cause and treating the cause. Also recommend increasing consumption of iron-rich foods, and oral or IV iron supplementation may be needed. Consumption of supplements such as vitamin C should be increased, as vitamin C helps promote absorption of iron. Macrocytic anemia is often seen with vitamin B12 deficiency and folate deficiency. Vitamin B12 and folate are necessary for the normal development of red blood cells and other bone marrow cells such as thrombocytes and leukocytes. The impaired DNA synthesis due to the vitamin B12 and folate deficiency is characterized by a delayed nuclear development, but normal cytoplasm development leading to an asynchrony. The asynchrony causes large developing cells called megaloblasts and large mature cells that are considered macrocytic. Cell color is unaffected since hemoglobin synthesis is not affected. Vitamin B12 and folate deficiencies also cause premature precursor cell death through phagocytosis or apoptosis. Folate is regularly replenished through eating or supplementation. Poor intake is uncommon in countries that fortify foods such as the United States, but is common in chronic alcohol use, anorexia, or malnutrition from illness. It may also be decreased during pregnancy, lactation, or hemodialysis. Absorption occurs in the small intestine, and dysfunctional intestinal surfaces or removal of intestinal surfaces can also cause malabsorption, which is seen in Crohn's disease and those who have had gastric bypass. Some medications may also interfere with folate metabolism, including methotrexate and some anti-seizure medications. Vitamin B12 absorption requires intrinsic factor, which is a glycoprotein produced by gastric parietal cells. See Figure 3-21 in your textbook. The salivary glands produce transcobalamin 1 that binds to the vitamin B12 to protect it from gastric acid degradation. The binding of vitamin B12 and intrinsic factor is facilitated by pancreatic enzymes in the duodenum. The bound vitamin B12 intrinsic factor complex is then absorbed by the ileum and carried through the bloodstream, where some is stored in the liver. The stores for vitamin B12 are abundant, and deficiencies take longer to develop than folate deficiency. Inadequate vitamin B12 intake can lead to deficiencies, but the most common cause is pernicious anemia. With pernicious anemia, autoantibodies target gastric parietal cells or the intrinsic factor, and the autoantibodies impair production, and cause destruction of intrinsic factor and other gastric secretions, causing gastric mucosal atrophy. The inability of vitamin B12 and intrinsic factor to bind leads to significant decrease in absorption. Diseases associated with pernicious anemia include various autoimmune disorders such as Hashimoto thyroiditis, Graves' disease, and type 1 diabetes. Gastric surgery such as bariatric surgery or gastric cancer surgery can lead to reduced absorption, and so can surgeries of other diseases affecting the small intestine, as seen in Crohn's disease. Some medications can also reduce absorption, including long-term use of antacids such as PPIs or H2 receptor blockers, and metformin. Vitamin B12 absorption can also be impaired in the older adult and leads to mild deficiencies and does not result in anemia. Clinical manifestations of both vitamin B12 and folate deficiencies include fatigue, shortness of breath, and glossitis. Vitamin B12 is necessary for myelin formation, and deficiency is associated with the development of neuropsychiatric symptoms that are generally not seen with folate deficiencies. This includes symmetric paresthesias and altered gait. They may also experience memory and mood alterations such as irritability, depression, or even personality changes. Diagnosis is done through a CBC and peripheral smear, and results will typically show a macrocytic red blood cells with low reticulocyte count, and the serum vitamin B12 and folate levels will be low. A homocysteine test may also be completed and is elevated with both deficiencies. An MMA test can be done to help differentiate between vitamin B12 and folate acid deficiencies. If vitamin B12 level is low, the MMA levels will rise as the MMA is not being used, but it will remain normal with folate deficiency. Treatment involves replacement with oral or parenteral vitamin B12 or folate. Anemia of chronic disease and inflammation is considered a normocytic anemia. It's also known as an anemia of chronic inflammation and is the second most common anemia. This is caused by many different diseases or inflammation, including cancer, chronic kidney disease, CHF, and infections. This disease involves decreased red blood cell production by the bone marrow and shortening of red blood cell survival. The chronic inflammation results in cytokine release, and these inflammatory cytokines may lead to red blood cell precursor apoptosis and decreased erythropoietin secretion by kidney cells. Iron storage and transport also becomes dysfunctional. The cytokines then release hepcidin by the liver, and with increased levels of hepcidin, less iron is absorbed and iron becomes trapped in the macrophages. Anemia produced by anemia of chronic disease is often mild to moderate, and the symptoms are often associated with the underlying disease causing the anemia. Diagnosis is made through an H&P, and a CBC indicates a low reticulocyte count. Inflammatory markers and acute phase reactants may also be elevated. Treatment involves resolving the underlying disorder and anemia. Aplastic anemia is also considered a normocytic anemia. This type of anemia is rare but serious and is a result of the bone marrow failing to produce multipotent hematopoietic stem cell precursors. This leads to a lack of erythrocytes, leukocytes, and thrombocytes, which is also known as pancytopenia. The cells that are present, while they are low in numbers, are mature, normocytic, and normochromic. A lack of these blood cells can lead to complications including infection, hypoxia, fatty replacement in the bone marrow, and death. This may be temporary or permanent, and causes include idiopathic conditions, autoimmune conditions, medications, and treatments such as chemotherapy, radiation, viruses, toxins such as pesticides, arsenic, and benzene, genetic abnormalities, infectious diseases such as HIV, pregnancy, and cancer. Clinical manifestations include signs and symptoms of general anemia, leukocytopenia, and thrombocytopenia. As blood levels decline, clinical manifestations worsen. To diagnose, a CBC and bone marrow biopsy should be completed along with prompt treatment of the underlying causes and any complications as they arise. Excessive loss of red blood cells results because of acute blood loss. Therefore, their erythropoiesis may remain relatively intact. Red blood cell loss may be due to disorders that cause red blood cell destruction in the intravascular space, such as DIC, or extravascular space, such as autoimmune hemolytic anemia, or there can be defects shortening the lifespan as seen with thalassemia major. Acute blood loss due to trauma will cause a normocytic normochromic anemia because the bone marrow increases normal production to replace the red blood cells and compensate for the loss. Destruction of the red blood cells occurs with hemolytic anemias, and due to accelerated destruction, the bone marrow may not be able to keep up with this demand. Causes of hemolytic anemia may be idiopathic, autoimmune, genetic, infectious, and blood transfusion reactions. Maternal fetal blood incompatibility can also result in erythroblastosis fetalis, which is also known as a hemolytic disease of the newborn. Several hereditary hemolytic anemias are possible, including those that cause enzyme deficiencies, plasma membrane mutations, and defects in hemoglobin abnormalities. Sickle cell disease is where there is an abnormality in the genes coding for the globin portion of hemoglobin, and it is hereditary. In the United States, it is considered one of the most common inherited blood disorders and is more common in blacks. In sickle cell disease, a mutation in the HBB gene located on chromosome 11. And while this mutation of HBB can cause different abnormal hemoglobin, one of the clinically significant types is hemoglobin S. And when hemoglobin S is deoxygenated, it undergoes polymerization, which causes red blood cell injury and changes the shape of the red blood cell into a sickle. This change leads to red blood cell dehydration, further worsening the polymerization. The allele for the sickle cell gene is codominant. So, if a person inherits one abnormal gene and one normal gene, the person will have the sickle cell trait and is now a heterozygous carrier. Persons with the sickle cell trait do not usually have symptoms of sickle cell disease. However, in conditions of increased oxygen demand or dehydration, it can lead to sickling, which causes hemolysis and vascular occlusions due to clumping of sickled cells. It is important to be aware if you are a carrier as the need for pre-conception counseling. The mode of sickle cell disease transmission follows an autosomal recessive pattern. Those with sickle cell disease inherit two abnormal hemoglobin genes, and at least one of the genes needs to be hemoglobin S. And regardless of the type of hemoglobin S, the shape of the erythrocytes is distorted, especially when the body is low on oxygen or dehydrated. The erythrocytes will take an abnormal crescent or sickle shape. Sickling can be reversible or irreversible, and the less often there is sickling, the more likely the cells could revert when conditions improve. These cells can easily clog in small blood vessels and break into pieces that disrupt blood flow, causing a vaso-occlusive crisis. The sickle cells have a short survival time of about 45 days. Hemolysis occurs, as does anemia, due to decreased red blood cells. Sickle cell anemia is the most common of the sickle cell diseases and is more severe because of all of the individual's erythrocytes are abnormal. With sickle cell anemia, the red blood cells are normocytic and normochromic, as erythropoiesis is not affected. Manifestations due to hemolysis include fatigue, irritability, and pallor. It can also lead to jaundice and the development of gallstones because of the bilirubin from the red blood cell breakdown. The vascular congestion and attempts at splenic removal of sickled cells results in hepatosplenomegaly. And with repeated episodes of ischemia and infarction, the spleen can atrophy, resulting in an autosplenectomy. Most patients will experience acute, painful episodes or crises that can last hours to days. And the pain is caused by obstruction of small blood vessels as the sickled cells clog up the vessels, leading to ischemia and necrosis. The pain is typically sharp, intense, and stabbing, and the common location is low back, chest, abdomen, and long bones. Episodes can be triggered by dehydration, stress, high altitudes, fever, menses, and extreme temperatures. Besides experiencing acute pain during a crisis, many people experience chronic pain, which has more of a neuropathic component. Carriers of the defective sickle gene can be identified by hemoglobin electrophoresis, and a sickle cell test can also be completed to identify if the hemoglobin is normal or sickled. CBC will often reveal normocytic normochromic anemia, reticulocytosis, sickled cells, Howell-Jolly bodies, mild leukocytosis, and then bilirubin and LDH can also be seen. There is no single best treatment. Stem cell transplant is an option. Medications are available to reduce the frequency of a crisis, and avoidance of triggers is also helpful, along with oxygen therapy, hydration, pain management, blood transfusions, vaccinations, and genetic counseling when indicated. Thalassemia is a hereditary type of hemolytic anemia which results in abnormal hemoglobin. The abnormal hemoglobin is a result of an abnormal quantity of one of the two globin protein chains, alpha or beta, leading to alpha thalassemia or beta thalassemia. This thalassemia is most common in people from Mediterranean descent. Both types lead to destruction of red blood cell precursors and apoptosis, as well as hemolysis of mature red blood cells. Ineffective erythropoiesis is more significant in beta, while hemolysis is more significant in alpha. Beta thalassemia is caused by a mutation in the HBB gene, and the most common mode of inheritance is autosomal recessive pattern. The HBB mutation can cause a complete absence or reduced amount of beta globin synthesis. Severity of beta thalassemia is determined by whether the mutation is heterozygous or homozygous. With the absence or reduction of beta globin change in the beta form, unbound alpha chains accumulate and become excessive. The alpha globin is unstable and precipitates, causing destruction of precursor and mature red blood cells, hemolytic anemia, and iron overload. Mature red blood cells with abnormal alpha globin are destroyed in the spleen. The anemia produced is microcytic and hypochromic. Alpha thalassemia is not as common, and it is due to mutations in the HBA1 and HBA2 genes. These genes direct alpha globin chain synthesis, and many different types of alpha thalassemia are possible. The decrease in alpha globins results in the relative excess of beta globin. Inheritance patterns are complex because of the numerous gene combinations that may occur. Patients with alpha or beta thalassemia minor may be asymptomatic or have milder symptoms of anemia. In beta thalassemia major, the manifestations and complications include delayed growth and development. Children have skeletal deformities. Iron overload occurs, causing hepatomegaly and liver disorders. Splenomegaly also occurs, and heart failure may occur. Positive family history and blood work is completed that will show microcytic hypochromic anemia and possibly low iron levels. Polycythemia refers to an increase in red blood cells and hemoglobin, and the two types include polycythemia vera and secondary polycythemia. Polycythemia vera is a primary disorder in which bone marrow produces too many blood cells. It is considered a neoplastic disease because of uncontrolled proliferation of cells. This occurs to a mutation in the JAK2 gene, which is present in all patients with polycythemia vera. And the role of the JAK2 gene is controlling cellular growth from hematopoietic stem cells. The mutated clone cells develop with the usual necessary erythropoietin, and in addition to increased red blood cells, thrombocytes and leukocytes are also increased, but in a lesser degree. As the blood cell numbers increase, the blood volume and viscosity do as well, leading to blood vessel distension and sluggish blood flow. Secondary polycythemia occurs because of a disease or circumstance that leads to a decrease in oxygen levels. This may be seen in people who live in higher altitudes. Secondary polycythemia may also be seen in people who use steroids and have chronic heart and lung conditions. Manifestations may be present before or after diagnosis, and symptoms may include visual disturbances, hypertension, and splenomegaly. Pruritus after contact with water may be present, along with vasomotor and microvascular thrombotic changes leading to a burning pain in hands or feet with erythema, pallor, and paresthesia. Gouty arthritis and GI diseases may be noted, and complications such as blood clots in arteries and veins may be seen along with hemorrhaging, acute myeloid leukemia, and MDS. Diagnosis is often an incidental finding when a CBC is completed. Treatment is not curative, and goals are to relieve symptoms and to improve survival through prevention of complications. Iron overload may be the result of consuming or absorbing too much iron, but some diseases that require multiple packed cell transfusions, including thalassemia, sickle cell disease, or MDS. Diseases that can increase absorption include inherited anemias such as thalassemia and sickle cell disease. Hereditary hemochromatosis is a genetic disorder that's caused by several mutations on genes that regulate iron absorption, transport, and storage. Excess iron saturates transferrin until the capacities exceed, and when that occurs, iron starts binding to other proteins such as albumin. The non-transferrin bound iron excesses are absorbed by cells that have mechanisms to take in the iron in this form, such as the liver, heart, and joints. The iron then gets chemically transformed in the affected organ and becomes a reactive oxygen species, causing tissue damage, inflammation, and fibrosis. Clinical manifestations of iron overload are nonspecific and develop slowly and become more evident once there is an organ damaged. See page 142 of your textbook, which provides a list of 7 organs that can be damaged and the symptoms associated with each. To diagnose a CBC may be done, which could be normal or demonstrate or show other anemias. Iron levels, ferritin, and transferrin saturation are all high, and the total iron binding capacity is low, reflecting the inability to bind. Treatment may include phlebotomy or chelation therapy. Goals of therapy is to prevent organ damage. Platelets are necessary for coagulation, and thrombocytopenia refers to a low platelet levels, and the lower the platelet number, the higher the risk for life-threatening bleeding. And levels less than 15,000 can result in spontaneous bleeding without trauma. Thrombocytopenia occurs due to decreased production or increased destruction of platelets. Bone marrow disorders will lead to decreased production. Alcohol may pair hematopoiesis, and certain drugs can lead to thrombocytopenia. Platelets can also be decreased due to blood loss. Immune thrombocytopenia purpura, or ITP, is a hypocoagulopathy state resulting from the immune system destroying its own platelets. Development of ITP is autoantibody mediated, and the key mechanism is circulating IgG produced by the B cells reacting with a surface glycoprotein. The platelets are then destroyed in the spleen, and some are destroyed in the liver and bone marrow. Autoreactive cytotoxic T cells also impair production. This can be primary or secondary to another condition. Primary is the most common cause of isolated thrombocytopenia, and this can be acute or chronic. Acute ITP is more common in children, and this form is typically sudden and self-limiting. Chronic is more common in adults. Most people are asymptomatic with ITP, but may experience abnormal bleeding or purpura lesions in distal dependent areas. It is often an incidental finding with blood work, and diagnostic procedures are directed towards identifying the cause. Goal of treatment is to increase platelet count to a level that will prevent severe bleeding, and if the patient is already experiencing severe bleeding, to manage it. Thrombotic thrombocytopenia purpura is a coagulation disorder resulting from a deficiency of disintegrin. Sorry about that. So thrombotic thrombocytopenia purpura is a coagulation disorder resulting from a deficiency of disintegrin and metalloproteinase with thrombospondin domain 13, which is a gene that provides instructions for making an enzyme necessary for cleaving von Willebrand factor. This leads to platelets aggregating around the large von Willebrand factor molecules and increased clotting, which decreases available platelets. Fewer platelets then lead to bleeding. Therefore, TTP is characterized by microthrombi in the microvasculature, thrombocytopenia, and bleeding. The clots are composed of von Willebrand factor and platelets. TTP can be hereditary or acquired. Manifestations can be acute or subtle, and multiple systems can be involved, and diagnosis is usually achieved through a history and physical, CBC, peripheral blood smear, LDH level, and bilirubin. Plasmapheresis is the treatment, and a splenectomy and glucocorticosteroids may also be needed. Thrombocytopenia is an increase in platelet count. Secondary thrombocytopenia is more common than primary and is usually self-limiting. Primary occurs because of intrinsic platelet precursor issues, and various hematologic malignancies are associated with thrombocytosis. Coagulation disorders can increase bleeding and may be hereditary or due to alterations in synthesis or inappropriate activation of coagulation. Hemophilia A, or classic hemophilia, is one example of a disease of coagulation and is the most common type. It involves a deficiency or abnormality of clotting factor 8 due to a mutation on the F8 gene. Hemophilia B involves an abnormality of clotting factor 9 due to mutation on the FN gene. Factor 8 and 9 are part of the intrinsic pathway that lead to factor 10 activation, and the severity depends on the amount of factor present in the blood. Those with hemophilia A typically have a more severe form of the disease when compared to those with hemophilia B. Severe forms may be present by 1 month of age, and milder forms are normally diagnosed by 1 year of age. Bleeding is the main symptom, and this may occur in the GI or urinary tract, bleeding into joints, petechiae, and overall bruising. Diagnosis involves looking at platelets, PTT, and PTT. Genetic testing is also conducted, and treatment includes replacement of clotting factors through transfusions of factor 8 or factor 9. Von Willebrand disease is the most common hereditary bleeding disorder. Results from a mutation on chromosome 12 that causes a deficit of von Willebrand factor, which ordinarily causes platelets to aggregate and adhere to the vessel wall in times of injury. There are several forms of von Willebrand disease, including type 1, which is the most common and mildest form, type 2, which leads to moderate or severe bleeding, type 3, which leads to severe bleeding problems and is due to the lack of measurable von Willebrand factor and factor 8. acquired type, which cannot be passed on to offspring and can occur due to hypothyroidism, lupus, or Wilms tumor. And lastly, spontaneous type is rare and is caused by a spontaneous mutation which can be passed to offspring. Some cases of von Willebrand disease can go undetected, and in more severe cases, it can cause bleeding without reason. Abnormal bleeding can occur frequently or hard to stop. Easy bruising or mucocutaneous bleeding are other signs. Diagnosis requires hemostasis evaluation and factor VIII levels along with other tests to evaluate the von Willebrand factor. Disseminated intravascular coagulation, or DIC, is a life-threatening disorder that occurs as a complication of other diseases and conditions. Normally, during injury, clotting factors become activated and travel to the injured site to help stop the bleeding, and then through fibrinolysis, the clot is dissolved. However, in persons with DIC, coagulation and fibrinolysis becomes abnormally active and ongoing, leading to the development of multiple microvascular and large vessel clots. These clots cause tissue and organ ischemia, impaired perfusion, and ultimately multiple organ dysfunction and syndrome. The clotting factors then get used by creating a consumptive coagulopathy, and the platelets, anticoagulant factors, protein S, protein C, and antithrombin are also used up, leading to bleeding. It is not clear why certain disorders lead to DIC and others do not. There is a list of major conditions associated with DIC on page 149 of your textbook. DIC occurs either acutely or chronically, and both cause bleeding and or thrombosis, with acute being more severe. Clinical manifestations tend to be multi-system, and they also oftentimes show signs of bleeding, such as petechiae, hematuria, and bleeding from IV sites. Diagnosis consists of a CBC, PT, and PTT. D-dimer, fibrinogen, and anticoagulation factors are also evaluated. Management involves identifying and treating the underlying cause. The treatment also consists of a delicate balance between preventing clotting but treating bleeding. And lastly, thrombophilia. This is a state of increased coagulation and is due to an abnormality in the coagulation system, leading to the tendency to form venous thromboembolisms. Antiphospholipid syndrome is an example of an acquired type of thrombophilia, and arterial and venous thrombosis are a complication. Inherited causes are commonly due to factor V laden and prothrombin mutations. Most individuals who have either inherited or acquired thrombophilia develop a thrombus in times of immobilization or with cancer. Treatment is dependent on the degree and risk of thrombosis.